Hello, my name is Professor Harminder Singh Dua. I am Chair and Professor of Ophthalmology at the University of Nottingham in England. Cornea transplantation has been performed for more than 100 years. But of late we have seen some tremendous progress whereby instead of performing a full thickness graft, we can replace the front of the cornea in a procedure called deep anterior lamellar keratoplasty when the front of the cornea is diseased. And if the endothelium is diseased, then instead of replacing the whole cornea, we can replace only the endothelium in a procedure called EK or endothelial keratoplasty. While performing deep anterior lamellar keratoplasty, we discovered in 2013 this new layer in the back of the cornea called the pre-descemetic layer, also at the time named the Dua's layer. This is a very distinct, tough layer of tissue which is mostly left behind in the operation of DAL. Many clinical procedures, surgical interventions, and even understanding of diseases of the cornea were improved by the knowledge of the existence of this layer. The most important of all of these is the operation of endothelial keratoplasty called PDEK or pre-descemetic endothelial keratoplasty. This is an operation in which we use an air bubble to separate the pre-descemetic layer together with the descemetic membrane and the endothelium in the form of a type 1 big bubble. This bubble wall is then excised and the whole tissue is inserted into the anterior chamber and applied to the back of the cornea as an endothelial graft. This is very similar to DMEK, which is descemetic membrane endothelial keratoplasty, but has some advantages. Because it is a tough tissue, it rolls less, and when it rolls less, it is easier to unroll in the eye, and therefore the tissue handling is less and endothelial cell loss is also less. This procedure adds only about 20 microns of additional tissue to the endothelial graft, but visually it has absolutely no bearing on the outcome. The visual acuity is just as good with PDEK as with DMEK. The other important advantage, and it's a very big advantage, is that donors of any eye, of any age, can be used for PDEK, but not for DMEK. We have done PDEK with eyes as young as 1 and 2 years old. Here the endothelial cells are very high in their counts, and therefore the outcomes are also much better, and the patient, even with a lot of corneal scarring, tends to improve corneal clarity rapidly when young donors are used. So there are two big advantages of the PDEK technique. The surgical technique is now being improved all the time. We have a PDEK clamp which guarantees a type 1 bubble if the centration in the clamp is perfect at the time of injecting air. And we are also developing new cutters with which we can cut along the circumference of the tissue without creating any irregularities. And this is a disposable cutter which is in the pipeline. And we are also now developing with the help of the company, which I should mention, Yanek, who has developed the PDEK clamp and the cutter, a disposable PDEK clamp which will allow us to get the type 1 bubble for PDEK operation with a greater degree of reproducibility. Thank you.